Study Designs in Pharmacoepidemiology Case Control Study Part 3. Learning Objectives. Understand how to calculate odd ratio. Identify sources of bias in case control design and how to deal with them. Analysis of case control study. As we said previously, the odd ratio is the measure of association and the only valid measure to assess the relationship between exposure and outcome, and we talked about this previously. The second issue is to control for extraneous variables or confounding variables. What is a confounding variable? It's a third variable that interferes with both the exposure and the outcome of interest. So here A is the exposure, B is the outcome, C is a confounding variable. It have an association with the exposure and also it have an association with the outcome of interest. Let's look at this example. I want to assess the association between smoking and lung cancer. Age is a confounding variable. Why? Because there is a relationship between age and lung cancer. As we age, there is increased chance of lung cancer. Also, there is an association between smoking and age. There is another association. So now, the presence of this confounding variable age could affect the relationship between smoking and lung cancer. For example, we conducted a case control study. We have lung cancer cases. We have controls that don't have lung cancer. We go retrospective and assess the exposures, including smoking, and we found a relationship. This could be a false relationship between smoking and lung cancer because the presence of age. We didn't deal with age. So the majority of our study sample were patients older than 75 years. So as we aging with time have relationship with lung cancer and smoking. So this relationship between smoking and lung cancer is no longer valid. How we can deal with confounding? We can control for confounding at design phase or analysis phase. At design phase, for example, we restrict our analysis we eliminate elderly patients from the study. This is an example of restriction. Better than this is to do matching. So we match our cases or controls based on age. So this matching could be individual matching or it could be group matching. At analysis level, we can adjust for aging in the model. You can't know this at this level because this is part of statistical tools. So at statistical analysis, we can adjust for age. We can stratify. We do the analysis per groups. So we conduct an analysis for young adults, for older adults, for extremely old adults, and we see how the relationship change as we age. Or we can do a multivariable adjustment, logistic regression model, Cox regression model, to overcome the confounding variable. We said in the previous slide matching. A lot of case control studies are termed as matched case control study. So what we do by matching is after we select our cases, before choosing our controls, we match them to certain important criteria or important risk factors. For example, we match them to age. Matching to age could be individuals. For example, for each case, I have cases. For each one, I have matched controls with the exact same age, or I choose to do it by groups. So for example, I put a group, 4 or 5 group of age, depend on the nature of the study. Let's say we choose, for example, to have 30 cases. Their age group is between 20 and 30. We choose 30 controls, their age group between 20 and 30, and so on and so forth. Also, other variables include neighborhood, geographical area, type of work, gender, depend on the study. If factors is fixed to be the same in the cases and controls, then it can't confound. So if we match these factors between cases and controls, confounding is lost. Matches can increase power by matching more than one control group. So in order to have better conclusion, in order to add more power to the study, we can, for each subject, we have 4 control groups. The 4 controls could be all from the same group or from different groups. For example, in the study that assessed the case control study that assessed the relationship between aspirin and Rey syndrome, cases where children admitted as with Rey syndrome controls, they had 4 arms. The first arm was children who were admitted matched by age and gender and admitted to the same hospital in the same time. Children the same age, the same gender, admitted to the same hospital but not in the same time. The third arm was children who go to clinics matched by age and gender. And the fourth arm was children who go to the same schools as the cases. So they had 4 arms from 4 groups of controls. Other designs could include the same group, but 4 or 2 or 3 through 3 controls for each cases, for each case. You should know that matching more than 4 groups or more than 4 controls will not add any benefit to the study. The maximum of matching is 4. One concern that could occur is overmatching. If we have a study in which we match our cases and controls on many criterias, maybe the exposure will be also the same. So we lose the association, and this could dilute the association and lead to underestimation of the relationship between exposure and outcome. So matching should only happen based on the most important criteria of interest. One of the most important challenges we face in case control study is recall bias. It's a form of measurement bias. Presence of disease may affect the ability to recall or report the exposure. Example, exposure to OTC drugs during pregnancy use by moms of the normal and congenitally abnormality babies. So the mother who have congenitally abnormal baby will be more likely to remember her OTC previous exposure compared to the mother who have a normal baby. How to minimize this bias? We can blind participants to study hypothesis. So when we administer the study and we ask the questions, we don't tell the participants what is the hypothesis. For example, I'm looking to ask about honey given to babies less than 1 year old and its relationship with botulinum poisoning. We ask about different type of foods. We don't focus on asking the participant that we want to assess the effect of honey and botulinum poisoning. This could enhance them remembering general without focusing on certain and overestimating the exposure. Also, blind study personnel to the hypothesis, the one who administer the questionnaire or conduct the study, use explicit definitions for exposures and use control with an unrelated but similar disease. For example, heart tetralogy cases, we can use controls with hypospadia. Other issues in interpretations of case control studies, be aware of reverse causation, the disease or subclinical manifestation of it, resulting in a change in behavior or exposure. Example, obese children found to be less physically active than non-obese children. Multiple sclerosis patients found to use more multivitamins and supplements. This should be always considered when we interrupt our case control study results. Quick summary, advantages of case control study, they are quick and cheap, ideal for outbreaks, and you can check the CDC website where it talks about many outbreaks and there is a lot of examples of case control studies. Can study rare disease or new disease conditions. We don't have to follow up and wait for disease occurrence. So mainly many of oncology studies are we utilize case control study, can evaluate multiple exposures. I can use this study designs to evaluate different arrays of exposures. Disadvantages: uncertain of exposure disease relationship, especially timing. It's not as bad as cross-sectional study. However, it's not strong as cohort studies. Cannot estimate disease rates. We don't use it to estimate the incidence or the prevalence. Worry about representativeness of controls. As we said, choosing the control is a very challenging task, and any mistake could result in poor results or not generalizable results. Inefficient if exposure are rare. Notice I said here exposure is rare, not outcome is rare. So it's good for rare outcomes. However, for rare exposures, it's not an efficient study design. And it's subjected to selection bias, confounding bias, and recall bias.